Ladies and gentlemen, it is an honor and a pleasure to me to speak to you today about assessing the microcirculation. And the confession I wanted to make to you has already been done by the chairman, that I'm not a pediatrician. So I'm not going to tell you how to treat your patients. The reason I'm here is that I became involved in research of the microcirculation with the Department of Physiology of Professor John Inch. And the nice thing about physiology is that it provides you concepts which helps you to understand why things go wrong, while at the same time your monitor tells you that things are right. So I'm going to start a little bit with why we need another way of monitoring, particularly on the conditions of sepsis. I will show you some of the available microcirculatory imaging techniques, the way we analyze these data. But the main focus, the mainstay of my talk will be the concept of heterogeneity of flow. And I'll hope that I can explain it in theory and by showing you some of my videos. And I will end up with sort of philosophy, how the microcirculation might be an endpoint of resuscitation in the future. First, a comment that suits with the previous speaker, that we are doing things wrong in general with monitoring things. I think we all agree upon the fact that shock has to be defined something like an inadequate amount of blood flow going to a certain organ that is vital. But look what's happening. On your and my monitor, I usually have pressure, and if things get complicated, I add more pressures like central venous pressure or pulmonary artery wedge pressure. But what I wanted to know is whether there is an adequate amount of blood flow. Now, skip the regional blood flow, but let's look at the general blood flow. And if I were to be a reviewer of an article like this, I would say, well, this is a nice cartoon, the relation between systolic blood flow and cardiac output. But skip the line, because there is no relation at all. But we act as if there is. So that's something in general. We always have this need for this canary of the body that will tell us, like the mine workers going into the mine, and if the canary drops dead, things are bad, and we ran out of the mine. And that is a major setback in what we do every time on our ICU units. And then there is another problem, because hypovolemic, cardiogenic, and obstructive shock, on the one hand side, occur as a result of a decrease in cardiac output. And that leads to an anaerobic tissue metabolism. While with septic shock, at the other hand side, there is a distributive alteration, and we have cellular hypoxia in the presence of a normal or increased cardiac output. And I've put a quote of Professor Vincent in 2001. I want to be somewhat reasoned, but I could have placed a quote of Max Harry Weil in 1969. We already know that for a long time. So one of the issues I want to make is that we have to measure at the compartment where things go wrong. So look at the microcirculation when there is something wrong in the microcirculation. And we can do that. And today there is this technique called protoporphyrin phosphorescence quenching. You can forget it immediately, but I just want to make out that it is possible to measure the microcirculatory PO2. It's now even possible to measure the mitochondrial PO2, of course, in a research setting, and you hit a fluorescent substance with light, and the decay curve will tell you what the PO2 is. And this is a result with this technique. We have an animal that's been bled to death, and you can see at the upper line the mesenteric PO2. So that's the upstream compartments. And then you can see that concomitant with the decrease of the mesenteric PO2, you can see the decline of the microcirculatory PO2, which is the lower line. That is a pig in a hemorrhagic shock model. But the same animal, after LPS infusion, simulating sepsis, shows you that there is a almost normalization of the mesenteric PO2, while at the same time there is an extreme low microcirculatory PO2. And this gap, called the PO2 gap, that is something that's really typical for sepsis. So I always keep into the back of my mind this cartoon. Under conditions of sepsis, we have what we call microcirculatory weak units. They are shut down from the circulation. They have anaerobic tissue metabolism. They produce lactate and CO2. While at the same time, very close to each other, there are microcirculatory units that are well perfused. And that account for the fact that venular PO2, and in the end that is central venous VO2, might be maintained at an adequate level. So look at, for example, a technique like NIRS, which looks at the complete unit, and it will miss these dysoxic units because you don't see it. So the key problem seems to be autoregulatory dysfunction under conditions of sepsis. There is a pathological distribution of blood flow, and the microcirculatory weak units become dysoxic and shunted. And this is what we call heterogeneity. And as a result of that, and maybe via other pathways as well, there evolves mitochondrial failure. And this is a hidden organ. This microcirculation is a hidden organ distress, which we not sense by monitoring systemic parameters. Now, there is this technique which was introduced by Groner in 1999 in Nature Medicine, which is a handheld device. It's called OPS imaging, orthogonal polarization spectral imaging. It sends out green light, and this green light is being absorbed by the hemoglobin content of the red blood cells. And therefore, the emitted light shows you the dark holes in places where there is hemoglobin. And the polarization technique is meant to take away the scattering of the light. So it's important to understand that this technique does not visualize the vessels, but it visualizes the hemoglobin content. We have now moved on to a second generation. It's basically the same technique called side stream dark field imaging. Imagine the headlights of a BMW with a ring of light, and in the center the emitted light is being absorbed by a camera. It's the same absorption technique with green light, but it provides better penetration and beautiful pictures. Now, this is all theory, but the funny thing about OPS imaging is that you can actually show a little bit what's going on. This is a typical image of a healthy individual in the sublingual region. The sublingual microvasculature consists of a microvascular network. You can see there are large vessels, which are venules. There are middle-sized vessels, and there are the true capillaries, the real small ones. You can appreciate that there is a homogeneous distribution of flow, and that this flow is continuous. This is under conditions of sepsis, and this is a severe form of sepsis. But you can see, let's go back once again. You can see that there is still blood running from A to B with the same continuous flow in these venules. While at the same time, there are areas in which there is a standstill of flow. There is stop and go. There is sort of sluggish flow. It's continuous, but it is slower than you can see here. And there are areas in which there seem to be no capillaries anymore. We know that they're there, but there's no hemoglobin content anymore. So if you want to know what heterogeneity is, well, it's right here. And if you want to understand what shunt is, well, it's right here. There is no flow in this area, and still there is flow going from A to B. And we took this to different organs. You might say, well, if things go wrong under the tongue, what does it tell me? Well, these are villi, and they are my favorite because they're subtly moving structures protruding into the lumen, finger-like structures, and they have this delicate vascular structure going right up to the tip of the villus, and you can see that there are even shortcuts for the red blood cells to go back again before having reached the tip of the villus. It's a totally different microvascular architecture, but you can appreciate the fact that it's still a homogeneous pattern of flow and that it is continuous. Now, on the conditions of sepsis, you might argue, is your video running? It is. You can see it in the back in vessels that are not focused. But these are the same villi. They are stiff, shrunken, and there is almost a complete standstill of flow. And it is hard to imagine how, under these conditions, aerobic tissue metabolism should have taken place. These are the crypts of the colon. Again, a different architecture, but these are the crypts surrounded by ring-like microvascular structures. They form a fishnet-like structure, but there is a continuous flow and there is a homogeneous distribution. And on the conditions of sepsis, a different architecture, but the same pictures under the tongue. There are places in which blood is fairly quick running up and down, and there are places in which there is a complete standstill. Now, it's important to have a sort of quantification. These are nice images, but you want to say, well, I think it's a 2 or a 3. Well, we did that, which is a lot of work to do, but we basically divided the picture into 4 quadrants, and we focused on one vessel type, let's say the small vessels, which are below 25 microns. And then we divide all the types of flow into no flow, intermittent, stop and go, sluggish, the ones that proceed but are too slow, and continuous. And we do that for every quadrant and for every vessel cohort. And then we end up with the microvascular flow index. In quadrant A, the left upper quadrant, we score for small vessels a 2, which means it is a sluggish flow. And here it's continuous, continuous. And then we divide the sum of all these individual scores by the number of quadrants in which this vessel type is visible, and we end up with the microvascular index, flow index. And the overall index consists of 3 regions of the organ of interest. So in the end, it's an average of 12 quadrants. And we demonstrated in critical care 2 years ago that both for the inter-observer and intra-observer variability, both in microvascular networks and in repetitive structures such as villi, crypts, you can easily extend that to, let's say, glomeruli of the kidney, that we had a fairly good kappa, meaning that we had a fairly good agreement. Now comes the difficult part, because if things might be different between these units, and the images you recently saw were enhancements over 300 times, then what must it be like between 2 organs? So we conducted a prospective observational study in our hospital with new stomas in the course of abdominal sepsis. So you have an abdominal crisis, you go to theater, the surgeon opens up the bowel, constructs a stoma to create a new situation in which the sepsis is under control, and then they come to the ICU department. And we look with OPS imaging on day 1 and day 3 in the stoma. Now, we're very concerned about the surgical influence in this, on the microcirculation, by the procedure itself. So we had 2 control groups, one without patients, healthy patients who had their stoma for a long time, but one with patients with a less than 24 hour. Basically, I went to the recovery room, and immediately after the surgical procedure, I did OPS imaging. Well, the septic patients, it's a typical population. You can see it's an adult ICU, fairly ill with an Apache 2 score of 20, almost all on the ventilator. We use dopamine as first agent, and 5 of them had a stoma in the small intestine, 18 in the colon. And the first thing you can see is that the 2 control groups had a microvascular flow index, which is completely normal, which is a 3, and the 25th and the 27th percentile always is within this 3. And the other group, who had this very recent surgical procedure, also had the same microvascular flow index, whereas under conditions of sepsis, the microvascular flow index was significantly declined. And this suggests that what we see, the alterations we see in the microcirculation in this particular model is due to the sepsis and not to the surgical procedure. Now, if we look at the group level, one might argue that at the left-hand side, what's going on in the sublingual region on day 1, a decline and then an incline to day 3, is happening also in the stoma region. So they seem to act in the same way. But look at this scatter plot for all the individuals. Here is an individual with a microvascular flow index in the stoma, which is normal, which is 3, and an almost complete standstill of flow under the tongue. And vice versa, and everything in between. So on the individual level, you cannot predict what it will be like in the intestine when you look under the tongue. And this is sort of what Al Gore calls an inconvenient truth. Now look what happened in day 3. We lost some patients, some were discharged, some died along the way, but on day 3 there is a normalization of this flow, and therefore we now have a correlation of blood flow. So time is very important when you want to establish things like this. And when you look at the individual level, you can appreciate that all the individuals, 11 out of 13, move toward the identity line. So this is an inconvenient truth. It makes things complicated. Is it irrelevant? I don't think so. First of all, we have the paper by the group from Brussels, and they showed that if the proportion of perfused vessels went down with the same technique, and it persisted that way, this was associated with non-survival, with morbidity and mortality. And I'm very glad that this has now been reproduced in a completely different setting by Trejak and Stephen Hollenberg. It's done in the US of A, in the emergency department, in a setting of early goal-directed therapy. They used the same quantification technique as we used, and it's the same result. No overlap between the controls and the sepsis, and a gradual decline of the score when things go wrong. Another way of looking at if this is relevant or not is to look at the relation between these microcirculatory alterations and sublingual capnometry. And this is a paper by Jean-Jacques Leteur, and he elegantly demonstrated that if the proportion of well-perfused capillaries go down, then the PCO2 gap goes up. And the PCO2 gap is the difference between the regional CO2 and the arterial CO2, suggesting that there is local production of CO2, and that this is a marker for anaerobic tissue metabolism. And when this CO2 gap under the tongue changes, there is a relation with the change in lactate as well. And it's unlikely that all this arterial lactate exclusively comes from under the tongue. This is another landmark study in the field of the microcirculatory research. Peter Spronk and co-workers demonstrated that they had, I believe, 8 individuals who they resuscitated in the classical way you and I do it with severe sepsis and septic shock. And they gave them fluids, inotropes, and vasopressors. And after that, the microvascular flow index was still very low, 0.5 and lower. And the general idea at that time was that if you have such a severe septic shock, that there is an inability of the endothelium to respond. The concept of vasoplasia. And he gave these patients 0.5 milligram of nitroglycerin IV as a bolus, which is the equivalent for an adult of medication under the tongue when you have angina. And he demonstrated in all vessel types there was an immediate response of the microcirculation. This does not prove that nitroglycerin is good for your patients. Maybe it does, maybe it doesn't, but it is a proof of concept. There is a way to influence this picture. Well, the group of Brussels did that with dobutamine and demonstrated that if the proportion of perfused vessels went up after giving a little amount of Dobutrex, it didn't have influence on the systemic hemodynamic parameters. Again, it is not a controlled trial. Take into perspective also the influence of time and other therapy as well. I have difficulty in understanding how this works because, to my knowledge, there are no receptors for Dobutrex, dobutamine in the microcirculation apart from leukocytes. But then again, it's there and it might be valuable. So this brings to my conclusions. The microcirculation, in my opinion, is a hidden organ of distress under conditions of sepsis, and it is not sensed by all the parameters we use in daily routine in the ICU. Observation of the microcirculation by OPS and SDF imaging is feasible, both in the sublingual region and in this model of surgical stomas as well, and we have to push further to make it available for other vital organs. We have a semi-quantitative way of analysis. There are other ways to do it as well. Anke Top will give a talk tomorrow about her research on ECMO and the microcirculation, and she needs a different way because different things happen in the microcirculation, but we demonstrated that there is a good reproducibility. And on day one, in this particular model, there seems to be no significant correlation of the MFI between the sublingual region and, in this particular case, the surgical stoma. And the index will increase from day 1 to day 3, and the alterations in the stoma seem to be associated with the sepsis and not with the surgical procedure. The persistence of these microcirculatory changes during sepsis is associated with worse outcome, and there is a potential to resuscitate the microcirculation with drugs we already are familiar with, like nitroglycerin, with the potential of declining anaerobic tissue metabolism. But whether this is useful for our patient remains to be established. Thank you very much.